Obstructive lung disease, asthma and COPD. What's meant by the term obstructive lung disease? Imagine yourself drinking like soda, Pepsi or something, and instead of a nice caliber straw, you have this tiny coffee stirrer and you try to get Pepsi outside the cup, out of the cup. You will have hard time getting Pepsi out. So obstructive lung disease is you have hard time getting air out of your lung. Why? Because your bronchi are obstructed. Your bronchi are narrowed. And this is in contrast to the other big group of lung diseases that are called restrictive lung disease. In restrictive lung disease, the problem is you cannot get air into the lungs. In obstructive lung disease, you cannot get air out of the lungs. As a matter of fact, air goes into the lungs easier in emphysema than in normal. Why? Because in emphysema, you turn the alveoli into big balloons due to the destruction in the lung parenchyma. The alveoli become big balloons, and it's always easier to inflate big balloons according to the law of Laplace. The pressure needed to inflate a balloon is inversely proportional to the radius of the balloon. So the smaller the radius, the more pressure is needed. The bigger the radius, the less pressure is needed. So obstructive lung disease, I cannot get air out. Let's discuss the pathophysiology of asthma and COPD. COPD patients, chronic obstructive pulmonary disease, includes patients with chronic bronchitis and emphysema, and mostly these two elements are found together in almost all cases of COPD. It's very hard to find an isolated case of chronic bronchitis or isolated case of emphysema. And what we know also now is asthma could be included in this chronic obstructive pulmonary disease. When asthma is so prolonged, this can lead to some sort of remodeling in the airways, and this will lead to chronic obstructive pulmonary disease. The definitions of asthma, chronic bronchitis, emphysema, and COPD. Now let's start with the definition of asthma. What's asthma? Asthma is a chronic inflammatory disorder of the airways characterized by airway hyperresponsiveness. This is a key word here, hyperresponsiveness. Your airways are super sensitive to a variety of external stimuli, which results in episodic. This is another key word. Asthma comes in attacks. Asthma is not present all the time. It comes in attacks. Attacks of what? Wheezing, dyspnea, and cough. Wheezing, dyspnea, and cough. And you can add tightness of chest as well. Wheezing, dyspnea, and cough. And which is associated with variable airflow obstruction that is usually, but not always, reversible. The key words here in the definition of asthma are airway hyperresponsiveness, episodes, reversible airway obstruction. So I can reword this definition of asthma as asthma is attacks of reversible airway obstruction that is usually due to airway hyperresponsiveness. Asthma, attacks of airway obstruction, and this obstruction is usually reversible, and the cause of asthma is your airways are hyperresponsive. Chronic bronchitis, the definition is much simpler. It's a chronic inflammatory disorder of the airway resulting in chronic productive cough, episodic wheezing, dyspnea, and coughing. The key word here is chronic productive cough. Emphysema, a permanent enlargement of distal air spaces associated with destruction of lung parenchyma. And the key word here in emphysema is destruction. In emphysema, you destroy the alveolar septa. You turn the distal air spaces into big balloons. And as I said, big balloons are usually easier to inflate. So emphysema patients, COPD patients, have always hyperinflated chests. The air goes in easily, but it cannot get out as easy. So you get air trapping and their chests get bigger. Chronic obstructive pulmonary disease. What's the definition of this disease? It's a chronic inflammatory disorder of the airway associated with incompletely reversible airflow obstruction. Incompletely reversible. Notice in asthma, the airway obstruction was usually reversible. Here, the airway obstruction is incompletely reversible. This means you can reverse it but a little bit, which is usually progressive. COPD is a chronic progressive disease. Unfortunately, COPD, we were not able to lower the mortality of COPD, and which is characterized by episodic exacerbations. Episodic exacerbation. So the key words in the diagnosis of, or in the definition of COPD is incompletely reversible airflow obstruction. Incompletely reversible airflow obstruction, progressive disease. Now let's discuss the pathogenesis of asthma. In asthma, you have a great element of allergy. You are allergic to something. And when you inhale this allergen, let's say a pollen grain, when you inhale it, the dendritic cells, which are inflammatory cells present in the mucous membranes of your respiratory tract, is gonna engulf this allergen and will process this allergen and will present part of it on their external membrane and will present it to the CD4 helper cell type 2. Type 2 helper cell. The CD4 helper cell type 2, when it receives this antigen from the dendritic cell, is going to release some chemical mediators, some inflammatory mediators, mainly interleukins. Interleukin 5 will stimulate eosinophils to secrete cytokines and leukotrienes. And interleukin 5 and 4 and 13 will stimulate the plasma cells to produce more IgE, immunoglobulin E, that dwells on the surface of mast cells and will lead to mast cell degranulation with the release of histamine, leukotrienes, prostaglandin D2. The whole process, as you see, is allergic, a lot of allergy. You have IgE, you have eosinophils, you have mast cells, a lot of allergic inflammatory cells, and you have the chemical mediators, histamine, leukotrienes, prostaglandins, cytokines. All these are kind of allergic. The whole process will lead to acutely bronchospasm, bronchial wall edema, and increased mucus secretion. On the long run, your bronchi become hyper-responsive and you get chronic bronchial wall inflammation, and the airway smooth muscle will hypertrophy. This is the beginning of airway remodeling, and all these will lead to airway obstruction with increased mechanical work of breathing. We have two types of asthma depending on the age of presentation. When asthma patients present at a young age, you can usually detect a very clear picture of allergy. So patients who initially present as children tend to show more allergic type hypersensitivity to typical antigens. And you can find a history of hay fever in father or mother, some allergic tendency in the family history. Whereas intrinsic asthma, patients who initially present as adults tend to show more non-allergic sensitivity to irritant inhalational exposure like cigarette smoke, air pollution. There is no specific allergen here. Their illness may seem to be triggered by an acute pneumonia. Extrinsic asthma, allergy in children. Intrinsic asthma, less allergy, and in adults. As for COPD, the pathophysiology of COPD, in contrast to asthma, you will find more destruction than allergy. More destruction than allergy. And it all starts with cigarette smoke. Cigarette smoke. When you inhale this cigarette smoke, the alveolar macrophages in your respiratory tract mucosa will engulf this smoke and will, as a result, will release interleukins. Interleukins 8. Interleukins 8 will stimulate the neutrophils in your respiratory tract to release proteases. What are proteases? Any word that ends with an ase is an enzyme that digests the first half of the word. So proteases, these are enzymes that digest proteins. So these proteases will digest, will destroy the proteins in your lung parenchyma, and this leads to destruction of lung parenchyma. This is emphysema, and will destroy the collagen in the proteins in the collagen in your bronchi, and this will lead to narrowing of the bronchi. Also, the interleukin will stimulate CD8, which is cytotoxic T cells. As the name implies, cytotoxic, it implies destruction, and it releases tumor necrosis factor alpha, which leads to destruction. So as you can see here, all are destructive cells and destructive chemicals, because the key word in the pathophysiology of COPD is destruction. The key word in the pathophysiology of asthma is allergy. And these are the consequences of a cigarette smoke with its chronic lung inflammation induced by it. You get increased fibroblasts, you get increased proteases, you get increased airway mucus, you get a defective immune system, you get hypoxemic vasoconstrictor response in the lungs. And as a result of this, you get the small airway fibrosis, you get the destruction of lung parenchyma, you increase the mucus content in your respiratory tract, and you get pathological bacterial colonization of your lungs, and this hypoxic vasoconstrictor response will lead to pulmonary hypertension. All these mechanisms will lead to the primary features that we see in COPD patients: the airway obstruction that is chronic, the hyperinflation and the hypercapnia and the hypoxemia and the chronic dyspnea and the predisposition to lung infections with chronic cough, and also the signs and symptoms of right-sided heart failure, what we call cor pulmonale. Traditionally, we used to divide COPD patients into patients with chronic bronchitis, and we described them as blue bloaters, and patients with emphysema, and we described them as pink puffers. This is no longer accepted, because we know that most patients of COPD have an element of both chronic bronchitis and emphysema. It's very hard, and it's not going to help you in the management. The management is one and the same, so it's not going to make any difference in the management. So I would rather not waste time in this. I just put it for you as a historical thing. So this table just provides a summary of the cells and chemicals involved in asthma and COPD pathogenesis. As I said, the key word for asthma is allergy, and the key word for COPD is destruction.